Hi, it's me, Ingviline of P. And I'm going to continue this series from my conference about the Cardiopulmonary Conference that I went to in Stockholm. It's been a few weeks now, but I wanted to get to one of the more interesting topics, which is about surveillance in medicine. Is it good or bad? And so there were a series of 3 lectures. Each lecture was 15 minutes, and then they had a panel. The first one was about blood pressure and taking blood pressure at home rather than at the clinic, which is much better to taking it at home, because a lot of people have white coat syndrome, which is when you come to the clinic and then you see a person with a white coat, a doctor or a nurse or something, and then your blood pressure skyrockets. So your blood pressure at the clinic is higher than at home. And they've done studies to see that the home blood pressure correlates with different things, like having a hypertrophy of the heart, or if you get atherosclerosis in your carotid artery, I don't know. And it predicts cardiovascular mortality and morbidity, so you can calculate the risk from the home blood pressure. And that is not, it's entirely independent of the blood pressure that you get at the clinic. So that means that it's much better measure to use, while the blood pressure that you take at the clinic is not as reliable. They found out that through their studies that clinic blood pressure of 140/90, which is high, you want to ideally be over 100, under 130/85. A blood pressure that is 140/90 at the clinic corresponds to 133/82 at home. So it is lower by around 7 to 8 points, which is quite a lot, because it can be the difference between a blood pressure diagnosis or not. That's in general. It just means that a blood pressure that is taken at home has the same cardiovascular risk as this clinic blood pressure. It doesn't mean that if you have this value, you will get this value at home, because that is individual for each person. So it's important to give advice on how to take blood pressure. You need to have your feet on the ground, firmly on the ground. You need to have your arms in heart height. You need to be relaxed in your back and in your feet, and you need to have been quiet, you need to take it in silence, not talk to anybody, and you need to have rested for 5 minutes. So you don't need to be lying down or anything, but sitting up in a comfortable position and not be stressed out. And the way to do blood pressures at home to get the actual, the best level, the best average, you take 2 measurements in the morning and in the evening for 7 days. And then you take the first day. So not day number 1, you take day 2 to 7, and you do an average of all of those, basically. And this is interesting for me, because I get people who, like, some people will take their blood pressure like for 3 weeks every single day. It's better to take one blood pressure in the morning and one in the evening. Sometimes it can be good to check it twice in a row. But in general, it's one in the morning, one in the evening for 7 days, and then you take off the first day. And the blood pressure is always lower when you're most relaxed. So often that is during the weekends, and often it's worst on Mondays if you work a regular work schedule. So don't do this kind of testing for a week if that is your like a week that you're on holiday, because it won't be representative. So that was pretty interesting. Then we got to the next lecture, which was about arrhythmia, and mostly they were talking about atrial fibrillation, which a lot of people have it chronically. That means that their heart is always having atrial fibrillation, meaning that their atrium, the first part of the electrical system of the heart, doesn't pump right, it doesn't give the right electrical signal, and so your pulse becomes irregular. But some people have this only sometimes, and some people have it chronically, often older people. And some people have atrial fibrillation, but they're asymptomatic, and so you don't know. And at what point is it a disease, and who should be checking their pulse? Healthcare can measure your pulse through ICDs, which are in-operated pacemakers. And they're pacemakers that don't give an electrical stimulation. They're just there to control. So it's just surveillance, basically. But you can also have a pulse watch, which a lot of people have nowadays. And how good are those watches? Well, apparently some of these smartwatches check your pulse 1 minute every 2 hours, and then they will increase the controls if they notice that the pulse is irregular during that minute. And that is one way that it can work. We're not sure exactly how all of these smart watches work. They seem pretty reliable. The pulse at least, but not the ECG ones, not really yet. There are all sorts of smart devices that can check your vital parameters. There are, toilet seats that can analyze the contents of your feces, and there are also these shopping carts that can measure your pulse when you're holding the handlebars. All sorts of fun stuff. So the thing is, how are we doing these measurements? And there are measurements that are Holter ECG, which is 24 hours, which is the usual way that we check the pulse and the ECGs. Because if you just take at one point an ECG, then that's just your pulse at that moment. And you're maybe not having an atrial fibrillation during that moment. So you don't catch all the people who have atrial fibrillation. At the same time, you might catch just one moment where they have atrial fibrillation, and then they don't have it the rest of the time. So you would only know through having 24 hours if it happens during those 24 hours. And do we miss some because it doesn't happen during that 24 hours? How much atrial fibrillation during a day is it important for us to catch? We don't know. They did a study where they put these ICD pacemakers into people to check for atrial fibrillation. These were people who were asymptomatic. And they don't feel any arrhythmia, they don't feel any heart stuff, but at the same time, those that they found with atrial fibrillation had, basically they found 30% of people had atrial fibrillation out of this sample of asymptomatic people. And it's like, what are you going to do with that? Are you going to give them anticoagulants, blood thinners, or not? And blood thinners do decrease the risk for stroke, so because you won't get blood clots. But at the same time, you get a higher bleeding risk, so that's not good either. So we don't really know at the moment what to do with this. But I do want to tell a story about this. I had a patient who, he came in for his diabetes control. He was around 50. So it was a little bit strange that he had, but he had a pretty well-controlled diabetes. He only took metformin once a day, and he was doing quite well. Not like overweight, but you know, he kind of had a little bit, he was a strong guy, you know. But the diabetes nurse said, yeah, she came running up to me and said, this guy says that his digital, like his smartwatch, told him that he had a low pulse. And now I took his blood pressure, and his blood pressure is also low. And well, sometimes the pulse can be low if you are a person who exercises a lot, who's young and you know, healthy. But I was like, okay, well, we need to check this. So we did an ECG, and his pulse was 38 or something. And, you know, I'd say a pulse is low if it's under 50. Under 60, it can be explained by somebody who is very athletic, but at that point I was like, this is not normal, you know. Actually, we had to do it twice, because the first time it was like normal, and then I was like, this isn't right. So I sent him to the emergencies, and he went to, at first I thought from the ECG that what was happening was that he was getting a heart attack, because I wasn't thinking that much about the pulse. I was thinking about like a heart attack for some reason. Anyway, he said that he wanted to stop at a fast food chain on the way to the hospital. And I was like, no, don't do that. That's like the worst place you need to go. And he's like, I'm so hungry. I need to get something to eat. He said, can I go home? And I was like, no, you can't go home. He's like, but then that means that I need to get something to eat fast. And what's better for fast food than a fast food restaurant? Drive-through. And I was like, no, don't go through the drive-through, like eat a sandwich or something, but please don't eat at the fast food place. So he ended up getting there, and they found out, they observed him throughout the night with an ECG, and it ends up that his pulse went down to 28 during the night at a certain point. And so they drove him to a bigger city where they gave him a pacemaker. And he didn't have atrial fibrillation, he had an AV blockage. So the electrical signal was not going from the atrium to the ventricles, which is the way that the electrical signal goes. It goes from the atrium to a certain node in the middle, and then to the ventricles. Well, the node was like blockage. So the signal was just going around and around and around in the atrium and never coming to the ventricles. So the ventricles could not contract, and the pulse was slow. So, and then he thanked me and everything was all great. But so in that case, the fact that he noticed that he had the smartwatch actually saved his life. Now, I don't think that is very common. It's more common that like people will get really stressed out about seeing their watch and seeing that their pulse is going really high and really low, and your pulse goes up and down all the time, all day, you know. So I wouldn't be that worried, but I would be worried if like the pulse is like over 100 constantly, or if it's under 40 constantly. Then I would be a bit worried. So then I would go to my doctor, basically. But yeah, so that was my little story on that. Let's go to the next lecture in the series, which was about spirometry coupled to your mobile phone. And I've told you guys about spirometry, which is to discover if you have asthma. It's a little thing that you blow in, and then this one is something that you can take with you home, and that is coupled to an app. And this guy is doing PR for his own product, so take it with a grain of salt. So the thing is, how do we get people to take their medication? And like, how do we, this is something that I've talked to about in the videos before. Why would an app be exciting? You know, why do we use an app? Well, because it gives people motivation to do this. It also does a monitoring. So if you do the spirometry every morning or every evening or both, it gives you more incentive when you're doing it inside an app that reminds you, rather than like if you're just writing it down on a piece of paper. It's also good in pedagogy, like to show the patient that like, you see like this is how it works, this is how your asthma works, and that's pretty good idea. It coupled to an app that goes into the cloud, and I don't really know what happens. At the moment, we have a shortage of specialized nurses that are specialized in asthma and in COPD. So sometimes it will take several months before my patients go get the spirometry. From the date I send an email to her, or personal message, it takes sometimes a few months, and so this would shorten the time before they got a diagnosis and a treatment. So this would be great. Unfortunately, I'm sure that this costs a bit of money, but who knows, maybe that will be the future. So the way to get an asthma diagnosis is either that you do a real spirometry, the one that's at the clinic, before and after taking those short-acting beta agonists, a SABA, inhalation. And so it's supposed to get a 12% difference, I think. I'm a little bit confused about all these numbers, but yes, I think it's a 12% difference from, I forget if it's 12 or 15%. Anyway, you need to have a difference between before and after. It should be much better afterwards, or a certain percentage better to be able to have an asthma diagnosis. But you can also have variability during the day, so it should be a 10% variability over a day. And so if you're measuring it morning and evening, or even after a certain trigger or something, then you will see that there will be a variability. And that is also a way to get an asthma diagnosis. So by having this home spirometry would be great. Also, you can do several spirometries rather than just one, which is awesome. The only thing is we don't really know who would benefit from having this extra cost. We don't know, are the results reliable compared to a regular stationary spirometer? They're still testing it out. Okay, but it is kind of a good kind of monitoring, you could say, because it could help. At the same time, sometimes we need to also know like what information is actually important. Do we really need a spirometer like in the hands of everybody who can't understand the results? That's the kind of problem I have with the digital clocks too, is that suddenly everybody is their own doctor, and it's like it leads to a lot of people who are very anxious about their health because their pulse like varies during the day, or their blood pressure. Some people are like, wow, my blood pressure was like 10 points in the like at that time, but then it was like this 10 points lower at this point, and I hadn't even done anything different. And I'm like, it's normal that it varies during the day. But people don't know that. You need a lot of education about these things. That's why becoming a doctor takes so long. We can't expect everybody to know as much about healthcare than actual doctors. But apparently that's that's what people want. The public wants to like learn to treat themselves, and that is always positive, to that people are motivated to improve their health and their lives. But there is that part of the surveillance thing that I think leads to a lot of anxiety, and it's not the amount of measurements that you do that is better. It's not the more measurements that you do, the better. Sometimes it's excessive. So a lot of, I'm not going to say a lot, but some patients have called me and said that they wanted a whole body MRI scan. And I was like, what do you want to know? What would that show you? And they're like, well, I want to know if something is wrong. And I'm like, well, something is probably wrong. We don't know, and some things we cannot see, and some things we do see are not wrong. And we have to be wise in how we use our resources, and also we need to understand what it is we're seeing. Because if we're seeing if we have all this content, it's like being online, you have all this content, and media literacy, going down and stuff. People don't actually read. Okay, I mean, I'm guilty of this too. Sometimes I won't read everything in the description boxes in the YouTube videos because, well, I don't have time for that, But you have so much information at your fingertips that it's difficult to know what is actually important. And I have a hard time reading through 24-hour blood pressure registrations, because if I saw oh, the blood pressure was high at that point, and then I have to understand why is it at that point, at least it gives you a curve in the results, so you can see where it goes above and beyond. But it is such an intricate thing, and if I looked at every single blood pressure, all the data points, I would not be able to understand the information because I'm not prioritizing. I'm just accumulating information, and that is what is happening online as well. They're accumulating all of our data, but is it for good purposes? And sometimes the computer gets it wrong, and it's like, well, okay, I talked about swimsuits like one day, and then suddenly the algorithm starts showing me a lot of swimsuits, and I'm like, well, I just mentioned swimsuits casually. Why does it suddenly think that I'm obsessed with swimsuits? You know, it's kind of the same, but with healthcare, is that we need to focus on the right things and streamline it. And the more information that we're able to pick up, but through these AI or these monitorization things, the surveillance, you know, it's like the cameras in the streets, you know, you need to have people looking at the cameras, but you can't expect one person to like have control over everything that's happening on each camera all the time. That's why they usually look at the cameras afterwards, and just like, instead of looking at the whole film, they look at like what happened between 10:15 and 10:25, and then they zone in to one of the cameras. Kind of the same thing. You can't use all of the data points in order to actually get to a result that is understandable. So that's what is meant by surveillance. Is it good? Is it bad? Well, it's both. And when I barely take the blood pressure at my clinic, except if the patient hasn't been able to take it at home. I rarely take the blood pressure anymore because it's rarely accurate. I do it mostly for the theatricals of being a doctor, because a lot of patients just feel like they're being listened to and that they're taken care of. I listen to the heart and lungs because that is something that we haven't been able to automatize yet, or be able to take at home. You can't listen to your own heart. I mean, I could with my stethoscope listen to my own heart, but that's because I have trained ears. But thing is, I just take the blood pressure most of the time. I take it because it calms the patient down. Unless it's an emergency situation and it's somebody with like some kind of, who is having a heart attack, then yes, I'm taking the blood pressure. But for regular checkups, I'd rather people take it at home. Or what we have at my clinic is that there's a special room that's called the health room, where you can go to the reception and borrow a machine to take your blood pressure, and then you go to this room. It has a little curtain to shield you off from everybody else, and it's kind of like low lighting and like calming, and people can go there and take their blood pressure and that leave the values at the reception desk, and that's good. Also, people can fill in their blood pressures online, which is good for people who like live very far away, or people who take their blood pressures at home. A lot of the older people would rather they want to come and send me like a letter which states all of their blood pressures, which is kind of nice. But you know, they expect me to like respond somehow, but like I don't really know what to respond. I'm like, okay, that's great. You know, unless the blood pressure is really terrible, then I'm like, no, that's not good. But yeah, so also something I forgot to mention is that 24 hours blood pressure takes the blood pressure during the night, which there is no other thing that tests that. And there should be your blood pressure should go down during the night. And if it doesn't, that means that like you actually have high blood pressure that needs treatment often. So that was that. They realized also that they had a fourth. Well, basically they talked about other things during this conference, but now it's been a half hour, so I've talked long enough. Have a great day, everybody. Bye.